What's up, guys? Today we're going to cover some vestibular disorders. This is going to be an overarching thing. I will also make another video on central vestibular disorders. It's going to be PT related, so it will be talking about evaluation examination components, which is outside of the scope of the PTA exam. However, I don't think that it will be a bad thing to check out just to kind of see what are the different central vestibular disorders, how do they present, and how is it going to look different with treatment versus are peripheral disorders. So this is going to be like, this is PTA related, and then the PT one I'll also post in here. Again, that one outside of your scope of practice, but not a bad thing to kind of just sit and listen to. So don't take detailed notes, just kind of sit and listen to. So let's get into it. All right, here are our different types of vestibular disorders. These central disorders are the ones that I talk about in the other video, so I'll make a video on that. So just kind of seeing that, like, vestibular migraine, you get those symptoms with the, migraine headache. Migraines are a central disorder. It's a problem with the brain, so it'll show up a little bit differently. Brainstem strokes, again, those are going to affect the cerebellum. Remember, cerebellum is important for balance and coordination, so you'll see problems with that. Also, the vestibular nuclei, so like where the brain, connects to the cranial nerve 8 that kind of goes through the brainstem. So if you have a stroke there, that's going to mess up that pathway. Tumor, you got a tumor in the brain. This is not an acoustic neuroma. Acoustic neuroma is a peripheral one on the actual vestibular apparatus in the peripheral nervous system. This is like a brain tumor is causing problems with balance and coordination and stuff like that, which can also present as a vestibular disorder in cause and nystagmus. MS tends to present with a vertical nystagmus, so understanding that that could fall into our vestibular disorders. And then anybody who's had a concussion, all of the concussion, post-concussion treatment protocols are all different types of vestibular habituation exercises. So that's why this is probably the most common one that you will be seeing as a PTA, treating post-concussion syndrome with vestibular stuff. But essentially, it's going to be the same protocol of like different head turns, habituation to exercises. And habituation just means like getting used to it. Like if you have problems, turning your head side to side, and that's what gives you dizziness, you're going to practice turning your head side to side in a safe environment so then nothing bad happens to you. So that's the big thing. And then our peripheral ones, oh my gosh, what is happening? Our peripheral ones are going to be the ones you want to pay attention to, because these are the ones that you're going to most likely see. These get referred to like a brainstem stroke and a tumor. Like that's getting referred to like neurology, like neurosurgery. Like we don't get paid enough to deal with that. PTs don't even get paid enough. Like half of these, if I'm seeing these as a PT, I'm referring out to someone else. These are the ones we can actually do something about. So our most common one is our benign paroxysmal positional vertigo, which I will only be referring to as BPPV because that is a mouthful. So this is the most common one that you will see in the clinic. And then there's something called a vestibular hypofunction, which is essentially when you remember, when we turn our head to one side, there's the signal coming from that ear to the brain saying, hey, you're turning your head to this side. If you have a hypofunction, turning your head to this side doesn't register correctly with the brain, so it causes dizziness. So that's why you might see some people they're like, if I turn my head this way, I'm fine. But if I turn this way, whoa, it starts getting all messed up. That's the thing that you'll notice with those patients with a true hypofunction, that they end up with a nystagmus or difficulty with maintaining visual clarity when they turn their head. Vestibular neuritis is essentially you got vestibular problems, you got that hypofunction kind of thing showing up. Your nerves the peripheral nerves are all getting out of whack because you've had an illness. Essentially, just think of it as like when you get nerve pain when you're like really sick with a cold or something like that. So that's something that can pop up. And then Meniere's disease, this is actually one that might show up. Essentially, that happens also after an infection where you get like a lot of fluid buildup in your ear, and it causes all the sounds to be very muffled, but it also causes dizziness when you turn your head to that side because all the fluid is like blocking up the vestibular system. So that's why you're getting dizziness, nausea, vomiting, and a fullness and pressure in the ear. So that's what Meniere's disease is. Unfortunately, there's no cure. It happens in older individuals, and it's just the kind of thing where it's going to have to get used to life. And then labyrinthitis is going to be inflammation, kind of like vestibular neuritis, but it's going to be inflammation of the labyrinth in the inner ear. So that sort of thing. So you're going to have hearing and acoustic changes with this one as well. So these are our vestibular disorders. For the purpose of this lecture, we will be focusing primarily on BPPV because 90% of the time, if you're treating somebody with an actual treatable vestibular disorder, it's going to be BPPV. So let's get into it. Let's talk about the anatomy of the inner ear. Let's go, homies. Okay, so what happens is we have our three semicircular canals. We have, our posterior, our anterior, and our horizontal canal. And so the big thing about these is just understanding that when you turn the head in different directions, it's going to push the lymph. So let's say that we are turning our head, like this is our lymph node. Let's say this is in our horizontal canal. Let's say it's this one right here. If I turn my head to the left, my inner ear, so this is going to be in my left inner ear, my left inner ear is going to whoosh all of the endolymph the opposite way. So if I turn to the left, the endolymph will push to the right. So essentially this thingy here is going to be focused this way. It's going to be pushing all of our little hair cells. It's going to push them all to one side. And it's going to tell the brain that I'm moving that way. Essentially, think of these little hair cells. It's like, have you ever seen like seagrass in the ocean pushing back and forth? When the water goes one way, it's going to push it that way. And then when the water comes back in, it's going to push it the other way. So the hair cells, if they are pointing in a direction, what that does is as they point in the direction, so if I turn my head to the left, my endolymph rushes the opposite way to the right. And it's just a funky way that you would think about it. So I'm turning my head. It's going to rush the endolymph. Don't worry about the direction. Just understand, as I turn my head, the lymph in my inner ear is going to push the whole cupula with the hair cells one way. When it pushes them one way, that's the signals to the hair cells will signal these nerve fibers and say, yo, we turn in our head to the left, and they'll go whoosh. And then that's how your brain knows that you're turning to the left. If you turn to the right, it'll whoosh the other way and it'll be like, yo, we're turning to the right now. So essentially, as these hair cells move back and forth, that's how the brain knows what the hell's going on. Where are we moving? And so when you're drunk, all of this fluid in your ear gets really, 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 like, it gets actually, it thins out. So it moves faster. So like me turning my head to the left should just indicate I'm turning my head to the left. If you're drunk and you turn your head to the left, it really whooshes everything super fast the other way. So then you feel like you're spinning. That's why you get the spins if you're drunk. So that's what's happening in the inner ear. So just think about that. And that's also what happens if somebody's inner ear is not working right. So what we're essentially trying to do in this situation is get everything to line up in the right way. So that's what's happening here at the cupula. And so and that's all horizontal canal stuff. Now in the actual vestibular system as well, you're going to have like the ampullas and everything like that. All these other, the ampulla is this big area, and then you'll have the cupula being the big woof here. This is a lot of anatomy. Just follow what I'm saying. Essentially what's happening is if the crystals are not in the right spot, they will float around aimlessly inside of the canal. If they're in the right spot, they will fall to the right area of the canal and they will stay there and then calmly tell the thing, hey, we're doing this. We're here. We're going to be in this spot. This is how we're moving. If they get dislodged for any sort of reason, they're going to start floating around and they're going to tell the brain that it's moving in various different directions, even though it's not. So we want to keep all the crystals, the otoconia, in the right place, because if they're not in the right place, they're going to float around aimlessly, cause problems, wreak havoc, be chaotic, and make the brain think that we're spinning in circles. If we put them in the right spot, which is through our maneuvers, then they stay there and they're fine. Okay. You'll see these parts here, the utricle and the saccule. Essentially, that's for nodding our head up and down or tilting our head side to side. What happens is these otoconia will pull on this otolithic membrane and they'll pull everything in one direction. So like, let's say you nod your head down, the otoconia are going to pull that membrane down, which is going to pull all these hair cells in that same direction. As they pull in that same direction as the otoconia are pulling down, essentially what that means is it's telling the brain, hey, my head is tilted down because we're pulling the kinocilia and the sterocilia in the direction, which those are the hair cells. We're pulling them in the direction of going down. So then that's how I know I'm going down. And then it's going to tell the nerve fiber, hey, we're going down. Same thing. It's the same sort of situation. This is just up, down, and then these are all our weird directional planes, okay? So the moral of the story is, if you're going to take anything from what I'm just saying, when the crystals are running around crazy, they will cause vertigo. When the crystals are where they're supposed to be, they will signal normal changes in position that the brain can identify. If they're all over the place, it ain't going to work, and you're going to get multiple signals, and the brain's going to be confused and think you're spinning and puke. So essentially, end of the day, this whole system, we figured out how it works. We figured out how it flows. We use the flow of that to our advantage to put the crystals back in place. And that's BPPV in a nutshell. Now, big thing is, if they have a hypofunction, essentially we can't see it here, but there will be the cranial nerve 8 is not activating how it should. And then that just means that we're not getting the signals. So all of these have signals, and then they go through cranial nerve 8. If cranial nerve 8 is not working well, they're not getting the signals, so we don't realize where we're moving. So when we turn our head, we're like, that's a hypofunction. So not good. This snail thing is our auditory complex. So we don't really have to worry about that too much in the system. We were worried about the vestibular, but if you have Meniere's disease, that's causing fluid buildup in all of this. So that's going to mess up your hearing. It's going to make it muffled, and then it's going to make all this not move well. So that's how you get dizzy. So that's vestibular in a nutshell. Basically, our job, put the crystals where they need to go and get people less dizzy by making their head turns less symptom provoking. Anyways, let's talk about how does this happen? Most of the time, BPPV is random, and it just kind of pops up. So that's why when the patient's like, did I do something wrong? Blah, blah, blah. No, I'm sorry. It just kind of happened. So just letting the patient know, like, it's not their fault. Like, things happen. Like, it's going to be okay. No need to panic. We're going to work on this. If they had a recent infection, so when I talked about that neuritis or that labyrinthitis, like that inflammation is usually due to an illness. So ear infection definitely can cause that. Just regular common cold, which I feel like I'm getting right now, that can also cause it. So there's a recent onset of things. The PT is the one who's going to worry about the actual diagnosis of what's going on, but that's why you might see somebody just all of a sudden develop this. And then, as we talked about before, concussions will mess with your eyes, being able to focus on an object and not get dizzy when you move your head. Anybody who's had a concussion knows if you got a concussion and you immediately went on like an amusement ride thing, you will puke and you'll feel awful and you will not be okay, and you'll have a migraine for like 3 days. So again, concussions will definitely provoke all of these problems with the vestibular system. But remember, concussion is going to be a central disorder. So you have a specific protocol. It's the same kind of stuff you'll do for everything else. You're doing balance, you're doing head turns, you're doing VOR cancellation, which is where you look at your thumb and turn side to side. You're doing all of that stuff with your concussion patients. So PT will help set that up. It's a procedure called the VOMS, VOMS. It's vestibular ocular motor system. I don't know what it stands for, but it's got vestibular in the name. So it does that. But here are the things that your patient will complain about. If it's truly some sort of like BPPV or something like that. Dizziness is the big one. They might even name it as vertigo, that they know it's like the room is spinning, like how we talked about with the drunk spins. Please don't get drunk just to try to feel how this feels. It's not worth it. But the vertigo, definitely. The nausea, vomiting, stuff like that, that's definitely going to be vestibular stuff, especially if it's provoked by, like head turns, positional changes, stuff like that. Again, if you don't know that you're turning your head, let's say they have that hypofunction, you're walking through the grocery store, your friend calls out to you, you're like, hey, so-and-so, you turn your head really quickly, your brain doesn't register that, and then you fall over. Like, that's not good. So either balance difficulties or falls, which is why this is very important to address and get under control in our elderly population, because they already don't have good reflexes. And again, coordination deficits as well, especially if it ends up being brainstem related and messing with the cerebellum. Visual changes, as we talked about, they might have like a visual aura or something like that, or at least just not being able to fixate on an object in the room spinning. That's usually due to this nystagmus, which is also the big thing that shows up with BPPV and any other sort of vestibular disorder. Again, with the nystagmus, you'll see like the torsional twitching, that's fine, or you'll see the side-to-side twitching, which that's also fine. If you see straight up and down, that is a vertical nystagmus, which is considered due to a central disorder, which is bad, okay? So if you're treating a patient and they're getting better, and then all of a sudden you see this vertical nystagmus, you're grabbing your PT and you're being like, whoa, what the hell is going on? And you want them to confirm. The boards will just say refer out. But me, I'm saying just nystagmuses, they look weird. So I usually get someone else to look at it, or I'll even film it and be just like, what the hell's going on? But anyways, that could be indicative of something bad starting to happen. So just be aware of that. And it might just look weird, and it's all good. The boards is black and white. Real world vestibular therapy, weird. So how are we treating it? Again, the PT is going to screen for those red flags of like a brain tumor or something like very serious. And again, the patient should have a significant improvement in symptoms if it's truly like BPPV within like 3 to 5 visits. Even with a hypofunction, they should start feeling better, at least with these habituation exercises within 3 to 5 visits. So habituation, after you do, your Epley or whatever you need to do to assess if it's BPPV. Well, Epley will treat that. The Dix-Hallpike will identify it, but do your Epley and stuff like that for the patient. And then you're going to make sure you're doing habituation exercises. This is the most important. This is why we do not heavily medicate our patients who have vestibular disorders, because we're trying to get them to habituate to it. So this is like the same thing as like gradual exposure. So like if you're somebody who's afraid of heights, but your friend bet you, I don't know, or like you'll win $1 million if you do a bungee jumping kind of thing. And you're like, man, that's really worth it. I want to get less afraid of heights. Maybe you go to the 2nd story floor and you look down, you're like, okay, whew, that's a lot. Then you get used to that. Then you go to the 3rd story and then you look down, and you keep doing that up the whole apartment complex to get used to it, to get used to the heights. That's a good way to do it. Another thing is people who are afraid of like snakes or something like that, like starting with a picture of a snake for like 5 seconds, and then maybe you go to a different picture of a snake for 5 seconds, and then you do that for 2 minutes, and then you take a break and everything. Maybe the next time you go in, you're exposed to a video of a snake or something like that, eventually to the point where you're holding a snake. Like, that's habituation. You get used to the stimulus until it becomes less symptom provoking and you get used to it. So with habituation, it's that I'm turning my head side to side so I can get used to it. So then if my friend does call out to me in the grocery store, I'm not turning and falling over. Like a little bit of dizziness, your patient will complain of dizziness. That's why you get a baseline. Let's say their baseline was like a 2 out of 10 for dizziness. And let's say like you're doing your exercise and they're like, man, I'm getting up to like a 5. And then let's say they get to like a 6 and you're like, okay, like let's take a break. Let's calm down, because you don't want to push them to a 10 each time, because you don't want them vomiting all over the floor. But let's say you do those exercises, they go up to like a 6. And then the next visit, they're at like a 5. And then the next visit, they're at a 4. Like, that's improvement for the dizziness because you're getting them used to that. So habituation is super important. Again, for hypofunction, the VOR training is going to be important. So I believe I talked about this in the spinal reflexes. So this is a vestibular ocular reflex. So look at something behind the screen that's stationary at the wall, and you'll turn your head side to side. Our eyes will move to the left as our head moves to the right. And then our eyes will move to the right as our head moves to the left. And so when you move your head back and forth, you're still able to look at whatever you're looking at on the wall. And if you're driving or something, please don't do this. So you're able to look at whatever you're looking at in front of you, and the image is able to stay on the retina. So like, even if I'm looking at the word how, if I'm turning my head back and forth, I can still read it says, how do we treat it? Like, I can read that still, even though my head is shaking back and forth. That's what you're going to do for your vestibular hypofunction to help them out with that. With BPPV, you are going to do, this is probably what you'll see on the exam. You're going to do, the PT will do the Dix-Hallpike and the roll test to see which one it is. So if it's a positive Dix-Hallpike, you're going to do the Epley maneuver starting on that ear. So if it's the left ear that has, BPPV in the posterior canal, they'll do the Dix-Hallpike with the left ear down, and then they'll go into the whole Epley maneuver after you come down through that. And I have a picture. Oh, sorry. I have a picture on the next slide about it. Horizontal canal BPPV is only found in like 8% of people. I'm not even putting anterior canal because that's like 0.005% of people. If you got anterior canal BPPV, something went horribly wrong. But horizontal canal, they'll either do the barbecue roll or the Guffoni. I'm linking pictures of videos of these because they're complicated to explain. But again, it's not very common. Geotropic essentially means that when you turn your head to that side during the roll test, you'll see the nystagmus beats towards the ground. Apogeotropic means if you turn your head to the opposite ear of where the problem is, you'll see it beat upwards. like aggressively. So basically it just means which direction is the nystagmus going. It's still going horizontal and you'll treat it accordingly. Everybody, regardless of what the hell's going on, they need balance. They need to be on foam because that challenges the vestibular system the most. They'll close their eyes because that challenges the vestibular system the most. They'll do walking with head turns and stuff like that. It's all going to be important for all these patients to help with habituation. You just got to really see what's the main problem with the patient and work on that. So that's going to be another thing when choosing the most appropriate answer. All right, so there are many ways to do the horizontal canal maneuver. I'm just linking that down below. The maneuver is like ridiculous. It literally takes like 15 minutes. So your 91% of BPPV cases are posterior canal. So this is the Epley maneuver. So whichever ear it is, so this person has the right ear down. So they're going to go down with the right ear. You're going to turn the head 45 degrees. You're going to go down nice and quick and then hold it in about 45 degrees of extension, 45 degrees of turning. Rotation. So you'll be there, you'll hold that for 30 seconds, and then you'll wait for about 30 seconds after the nystagmus stops. The patient might be freaking out during this. So just tell them like, hey, it's okay, I got you. It's going to suck for a second. And then you always want to make sure they keep the eyes open so you can keep an eye on what's going on. Then with this, you'll turn the head to the opposite way. So there's still an extension. And then you're going to wait for 30 seconds after the nystagmus stops. And then you're going to have them rotate onto their side, facing the ground. Hold that for another 30 seconds after the nystagmus stops. And then you'll have them sit up and you're holding onto this patient as they sit up because you don't want them falling over because they might get dizzy. So again, you want to hold the position for up to a minute to see if the nystagmus provokes. And you always want to do this twice with a patient because it's more effective if you do it twice with them. So definitely know how to do the Epley. That is the most important one, most common. I've done this in weird positions. We've made it work. Yeah, and I'll post the other one as a link down below underneath this video. So our keywords are looking for that horizontal or torsional nystagmus because that means we can do something. If it's vertical, we cannot. That's beyond someone else who gets paid a lot more can deal with that. Vertigo or dizziness, if the patient's complaining about that, that's what you're looking for. Nausea and vomiting. Very common symptom. Positive Dix-Hallpike or roll test. Remember, Dix-Hallpike is for posterior canal. Roll test is for horizontal canal. If they have difficulty with head turns, that's also something that you want to look at. Might be a hypofunction, loss of balance, history of falls. Again, problems. Those are impairments that we can treat with balance and stuff like that. Recent illness. So understanding that might be why the person developed their vestibular neuritis. And then habituation is going to be one of our most important interventions in helping the patient get better and get more accustomed to their environment. Because we can't just tell them they can't turn their head ever again. Like they need to turn their head to drive. So yeah. Also, this person's going to be driven to their appointments. Don't let this person drive. And then Epley or barbecue roll will be our treatment for our BPPV, depending on which canal it is. All right, guys, here's our sample question. A physical therapist assistant is working with a patient that complains of dizziness when laying down in bed. The patient reports no difficulty with head turns or nods. Their main complaint is dizziness whenever they go down to sleep. The physical therapist assistant performs a specific maneuver twice to address the condition, and symptoms resolve about 90%. Which activity should the therapist do next? 1, habituation exercises, get the patient used to positional changes. 2, perform the Epley maneuver. 3, perform the barbecue roll maneuver. Or 4, VOR ×1 exercises standing on foam. So I'll give you guys a second to think about that. All right, so our answer is going to be those habituation exercises to get the patient used to positional changes. Our patient is mainly complaining about when they go to lay down that they get dizzy. They said, I feel good with head turns, nods, so we don't really need to do this one. That's not really addressing the impairment. We're not doing the barbecue roll because they said laying down in bed. So going down in bed to lay down, that's going to be posterior canal. If it was rolling over in bed, we'd think horizontal canal. So it's not going to be horizontal canal because it's laying down. That's going to be posterior canal, which would be, if it's posterior canal, we would do the Epley, but we already did it twice. And the symptoms have mostly resolved, which means we're going to get them used to habituation exercises to make sure that their symptoms stay resolved. Okay. So the most important thing for this patient based off of what they complain is those positional changes. So we're going to work with those. We're going to habituate them to those, and then maybe we'll do something else later. But right now, the patient's main complaint is that difficulty with laying in bed. So that's what we're going to address. Is this still appropriate? Yes. Is epilepsy maneuver appropriate? Yes. We just did it twice. Okay. So that's why this is the answer. All right, guys, I hope that was helpful. That was a lot. Let me know if you have any questions. Take care, and I'll see you in the next one.